Well, welcome to this year's Timely Topics, the Nathan Kaufman Timely Topics Lecture. And I have to say, I didn't think I would say this, because I have to say being president is not necessarily an enjoyable pastime. But I've enjoyed the last 20 minutes, because I knew who I wanted to invite to give this talk. And having now actually talked face-to-face with Gil Welsh, I've picked the right guy. So you know currently modern medicine, particularly in this country, is best described as over-enthusiastic, yes? People do loads more for mystical, brief extensions of life, more than they need to. We have ICUs full of 90-year-olds with pneumonia who should be dying peacefully at home instead of costing tens of thousands of dollars a day. Now, Gil has been in the forefront for the last 25 years of showing how screening, early diagnosis, something that sounds so important, is actually creating patients with disease when they don't necessarily have a disease that needs to be treated. And let me just tell you a little bit about him. He was born and raised in Colorado before marijuana was legal. And he got his undergraduate degree in economics at Harvard, went to medical school, University of Cincinnati, and then a master's in public health in the University of Washington. And he was hired to the faculty at Dartmouth in New Hampshire in 1990. And for those of you not from the US, Dartmouth is one of the Ivy League universities in these beautiful sort of New England woods, where it has a world-renowned group of people working on public health issues. I will have to look at the piece of paper to tell you all his titles, because they're quite remarkable. And then you'll discover how incredibly normal he is for having so many titles in about 3 minutes' time, when I shut up. So he is the professor of medicine in the medical school. He's a professor of public policy in Dartmouth College, which is the liberal arts component. And he's a professor of business administration in the Tuck School of Business at Dartmouth. I first became aware of him by reading the things that he writes in the newspapers. He writes op-eds for the New York Times, the LA Times, the Washington Post. He writes scientific articles in banal places like the New England Journal or JAMA and things like that. And he really has spent 20 years focused on this problem of overdiagnosis. So I think we're incredibly privileged to have him here today. I will recite his title, the title of his talk for you. Oh no, I have to tell you about his books. Damn, I nearly missed that. He's written 3 books, and the one that I read that I just thought was very cool is entitled, and you should go buy it, Overdiagnosed: Making People Sick in Pursuit of Health. Anyway, his title today is Overdiagnosis and Cancer Screening: Challenges Posed by Birds, Rabbits, and Turtles. So, Gil, please come to the stage. Oops. Have enough hands to oh yes. Welcome.
Am I good to go?
Yes, you are.
I'm good to go. Hey, how are you guys doing? I'm a general internist. I gather you're a pathologist, right? Just checking. Do pathologists know how to have fun? All right, we'll see. Well, here's some fun. I have no relevant financial relationships to disclose. What else do I have to say? Oh, if you care about CME, do whatever this slide says to do, okay? I'm going to start, it's a medical conference, right? So I'm going to start with a case. And it's a true case. And it had a huge influence on my career. Mr. Baker, not his real name, no HIPAA violation, was a 60-year-old former smoker who called me on the phone. A lot of my patient contact was by phone, with a chief complaint of hoarseness times 6 weeks, and I barely recognized his voice. But he was otherwise well. He never had felt sick. And I was working at a small hospital, White River Junction, Vermont, worked for the Department of Veterans Affairs, and one of the nice things about a small hospital is it's a small medical staff, and the otolaryngologist was right down the hall. And I said, could you look at this guy? And so he did. He did an indirect laryngoscopy, and found a small vocal cord tumor and removed it. And Mr. Baker's hoarseness resolved. He got a short course of radiation therapy, and he was told to return if his hoarseness returned. And that should be the end of the story, except someone along the way had ordered a chest x-ray. Now, some doctors might argue that he should have had a chest x-ray anyway, given the possibility of lung cancer. I mean, it's an unusual presentation of lung cancer, but you all remember going through anatomy, and they taught you about the recurrent laryngeal nerve, and it can reflect lung involvement. But I would counter that once we had found the cancer responsible for Mr. Baker's hoarseness, we did not need to go looking for a second cancer. But the horse was out of the barn. Keep it, leave it, lose it? Okay, sorry. All right, so here is the chest x-ray, and it showed a widened mediastinum. And what did the radiologist then say? What did the radiologist suggest? More imaging, sure, a chest CT was suggested. And we got a chest CT, and it showed a normal chest. You know, the patient was rotated a little bit, or I don't know, something was wrong with the chest x-ray. It was something wrong. But there's this little yellow line that you're probably familiar with. It moves up and down and stuff, and that kind of makes things hard for a chest CT. To get the entire chest, you have to get a little bit of abdomen. And there on Mr. Baker's right kidney was a 5-centimeter renal mass. Now, how many of you know ICD-10? You're getting that down, I hope? Yeah, so there's a term for that. That's an incidentaloma, right? And you all know that. That's an incident, we weren't looking for it. We just stumbled onto it. So let me just remind you the case. So we've got hoarseness progressing to kidney cancer. Now, I was never taught that in medical school. I never knew that. And of course it doesn't in terms of disease progression, but it can in terms of medical care progression, in our desire to always be sure and get all the information. Well, the urologist was sure what to do. She said, look, here's an otherwise healthy guy who has kidney cancer. Yes, it's major surgery, but because he's healthy, he'll sail through it. We've got a chance to save this man's life. That's a pretty evocative statement, isn't it? But Mr. Baker and I were less sure. I was just beginning to play with the Medicare data at Dartmouth. I knew that the 30-day operative case fatality rate following nephrectomy was between 2 and 3%. Well, that's not trivial. And Mr. Baker was apoplectic. You're kidding me, doc. I come in for hoarseness, now you want to take my kidney out? But the cancer surgeon persisted, and now she had statistics. She told me that because of early detection, the average 5-year survival for patients with kidney cancer had increased from 34% in 1950 to 62% currently. Wow, the urologist is quoting statistics to me. I was thinking, I'm the numbers guy. So I got to look at the numbers. So let's look at some numbers. So all the graphs I'm going to show you today are from United States data, from SEER, which is our National Tumor Registry. And I'm now showing you the graph for renal cell carcinoma. And this is the death rate, mortality rate. I'm curious, how would you describe that? I'd call it flat, right? It looks pretty flat. But there's nothing flat about the incidence rate. It's up 2.5-fold from 1975 to now. So here, I've got a couple of questions for you. What would you guess has happened to the number of nephrectomies over this period? Hello? Yeah, it's gone up. All right, tougher question. What would you guess has happened to 5-year survival over this period? I hear nothing, and I hear improved. Now, this is an important point. 5-year survival's a really tricky statistic. It has a numerator and a denominator. You ready? The denominator is among those diagnosed. It's among cancer patients. And the numerator is the number of the denominator that are alive 5 years later. So if you have more diagnoses, but you have more diagnoses minus the same number of deaths in the numerator, 5-year survival will rise. So even though mortality is totally stable, because we're diagnosing more patients, the typical patient appears to do better. This is a hard question. Is anything good happening? My answer would be no. Nothing good is happening in this graph. Now, because Mr. Baker was so adamant and said, Doc, there's got to be another way, we decided just to watch this tumor. And this is the mid-1990s. This is before this is really being done. And I was really nervous about this. And we repeated a CAT scan 3 months later, and maybe it grew a little bit. It was like 5.1. And then we repeated it again in 3 months. And now it seemed to shrink a little bit. I remember going down to radiology and watching them put the calibers up and measuring it. And then maybe it grew a little bit, and maybe it got smaller. Then I said, bam, we're doing a lot of CTs. Maybe we should go to 6 months. And so we go to 6 months. And it never really changed. Mr. Baker later died of pneumonia. He had an autopsy, and let me tell you, this was one autopsy I was definitely there for. I really wanted to see what was on that kidney. He had renal cell carcinoma, but beyond that one kidney, no other cancer was found. Mr. Baker had a diagnosis of kidney cancer for about a decade. He was never treated for kidney cancer, he never developed symptoms of kidney cancer, and he did not die of kidney cancer. He was overdiagnosed. And I learned a lot from this patient. He taught me 3 things. First, not all cancers invariably progress. Second, cancer survival statistics can be horribly misleading, particularly in the context of early detection. And 3, patients may know something we don't. I'm going to assume most of you know that third point. These first 2 points are the main points I want to focus on with you in the next 50 minutes or so. There's this widespread assumption in medicine that sooner is always better. And we've all been taught that the best way to deal with a feared disease like cancer is to look for it early, try to catch it early. But our understanding of cancer is changing. And ironically, it's changing because of the side effects of early detection. And we need to think about the word cancer differently. And that brings me to the barnyard pen of cancers. And there are 3 animals in the barnyard: the birds, the rabbits, and the turtles. And the goal of early detection is to fence them in, is to catch them early. But I think you can all see the problem. You can't fence in a bird. The bird's already flown away. And these represent the fastest growing cancers, the most aggressive cancers, the cancers that have already spread by the time they're detectable. Screening doesn't help with the birds. The question is, can you treat them? Now, the rabbits are hopping around, and you can catch them if you build enough fences. These are the more slowly progressive cancers, the cancers where screening has the potential to help, but may not, but it has the potential to help. And then there are the turtles, and you don't need any fences because these cancers aren't going anywhere anyway. These are things that meet the pathologic definition of cancer, but grow so slowly that patients die of something else before they ever cause symptoms, or they don't grow at all, or even more unusually, they in fact regress. And the unfortunate reality is that screening is really good at catching turtles. But doctors aren't good at distinguishing turtles from rabbits, so we tend to treat all of them, thereby causing the major harm of early diagnosis, overdiagnosis, and overtreatment. I want to share with you an article from Life magazine. It's called "The Plea Against the Blind Fear of Cancer." And it's written by a cancer surgeon at the Cleveland Clinic by the name of George Kreil. And I want to just read one paragraph to you. He writes, "In clinical practice, to say that a person has cancer gives us little information about the possible course of his disease, as to say he has an infection. There are dangerous infections that may be fatal, and there are harmless infections that are self-limited or may disappear." That sounds pretty reasonable. You understand that. And then this is a surprising sentence. "The same is true of cancer. Cancer is not a single entity. It is a broad spectrum of diseases related to each other only in name." How many of you subscribe to Life magazine? Just curious. I'm looking at some of the younger faces in the audience. They're saying, "Well, what is Life magazine?" You know, right? And even the older folks in the room remember it was like a long time ago that it ran black and white photos. This article was written in 1955, the year I was born. It's a rude reminder. I've never had an original idea in my life. It was probably George Kreil who originated the analogy of the birds, rabbits, and the turtles, but he was worried about this problem 62 years ago. Now, this is just recently from Lancet Oncology, and you'll see there's sort of 3 patterns of cancer growth. And on your right, you see rapidly progressive cancers that start with normal cells and quickly move to detectable metastases. Those are the birds. And then the slowly progressive that work through those stages that we would have all learned in medical school, in situ cancer, stage 1, stage 2, stage 3, stage 4. Those are the rabbits. And then on the far left, the indolent and regressive cancers, those are the turtles. And it's an uncomfortable reality for us, but there are a lot of turtles out there. And the way we know this is from autopsy studies. When autopsies are done in people who are not known to have cancer during life, who die from something else, but we look really hard to understand what the reservoir of the disease is. 1 to 3% of adults harbor unsuspected kidney cancers. That may not sound like much, but that's over an order of magnitude more than will ever die from kidney cancer. At least a third of adults harbor small thyroid cancers, and you all know this. Over half of men over age 60 harbor small prostate cancers. And about a third of women age 40 to 49 harbor the smallest form of breast cancer, the form of breast cancer some pathologists wish the word carcinoma had never been attached to, the so-called ductal carcinoma in situ. And then we encourage the well to get examined to determine if they are not, in fact, sick. Think about that for a second. We encourage the well to get examined to determine if they're not, in fact, sick. This is the new healthcare. That's screening. Now let me show you an advertisement that raises my blood pressure to dangerously high levels. And at the outset, it's a pretty attractive ad, right? They're pastel colors, and there's kind of nice script, and there's a nice charcoal drawing of an attractive young woman, could be my daughter. And underneath her face, it says, "It won't happen to me. I go to the gym every morning, I walk to the office, and I don't let work stress me out." So here's a young woman doing all the right things for her health. And then in the very small font under there, you can see it says, Alicia Fox, 21, the day before she was diagnosed with thyroid cancer. What is that ad designed to do? Scare you. Totally scare you. And in case the message is a little too subtle, the ad goes on to say, confidence kills. That's a great public health message, isn't it? If you feel good, you're about to die. I mean, it's crazy. It goes on to say this: thyroid cancer doesn't care how healthy you are, it can happen to anyone, including you. That's why it's the fastest growing cancer in the United States. Let's see, did any of you have logic in college? Does that even follow? Thyroid cancer doesn't care how healthy you are, it can happen to anyone, including you. That's why it's the fastest growing cancer? It doesn't even make sense. Oh well. Anyway, it goes on to say, ask your doctor to check your neck. And then it occurs to me, what we have here is a copy editing problem. Let's just reverse the sentences and see if it makes any more sense. Thyroid cancer doesn't care how healthy you are, it can happen to anyone, including you. Ask your doctor to check your neck. That's why it's the fastest growing cancer in the United States. I mean, now it makes sense. Okay, so what's happening in thyroid cancer? We're back to US SEER data. And thyroid cancer was actually, incidence was fairly stable till the mid-1990s, and then it shot up. Threefold increase. Now, if this was an epidemic of true disease, the genuine amount of disease was changing, clinically meaningful disease was changing, what would I expect would happen to the mortality rate? Well, I'd expect the mortality rate to go up. Or maybe I'd expect the mortality rate to go up and then go down after we had a new test or treatment that really changed the trajectory of the disease. But in fact, what do I see? Well, I see the most stable mortality rate in the SEER data. This doesn't look like an epidemic of disease. To me, this looks like an epidemic of diagnosis. And it matters. There are a lot of people under this curve, hundreds of thousands. 3/4 of them are women. In the United States, 80% of them have a total thyroidectomy. They need lifelong thyroid replacement. They are subjected to the risk of hypoparathyroidism and recurrent laryngeal nerve damage. That recurrent laryngeal nerve keeps coming back. I'm so glad I took anatomy in medical school. And is all that being done just for turtles? That should be concerning to all of us. Now, this is one place where the United States is not number one. The gold medal goes to South Korea. And this is the incidence of thyroid cancer in South Korea. It has increased 15-fold in 15 years. And I don't know any better example of how far wrong a strategy of early detection can go than this one. Thyroid cancer is now the most common cancer in Korea. It is more common than lung, it is more common than breast, it is more common than colon cancer. And unbelievably, they are now advertising this fact. Smart Care, Smart Choice Thyroid Cancer, Korea, the new heart of medical tourism. Now, this is a really important clinical point. This is not a sign of thyroid cancer. See, this? That is a sign of a stiff neck. I just want to make sure everybody got that. People walk in the office, that's not thyroid cancer. Believe it or not, it gets worse. They go on to say Korea, the country with the highest thyroid cancer survival rate in the world. What are they doing? They are taking credit for curing turtles. So those are my two take-home points. Not all cancers invariably progress. Increased incidence may instead reflect overdiagnosis, and we've got to be on the lookout for it. And second, cancer survival statistics can be very misleading. Comparisons across time and place often reflect different diagnostic practices, not different treatment practices. We're all sort of drawn to think, oh, it's about who's treating who better. But in fact, this statistic is highly sensitive to diagnostic practices. And thus, it can be subject to both lead time and overdiagnosis biases. And if you don't know what those are, I encourage you to go onto my YouTube site. I have videos on both those biases because they're very powerful. Oh, and you can get a dog to sniff out thyroid cancer. Did you know that? There's a lot of fascination of dogs and cancers these days. I don't know why, but I hope we look at a picture like this a little bit differently. This is a photograph from the Atlantic, and it's talking about the Affordable Care Act, which I am a supporter of. But this is an image that we're drawn to thinking, this is great. Someone is now getting access to care. But if that provider is examining the thyroid in a patient who has no symptoms attributable to their thyroid, that is screening. Almost all thyroids will have bumps. All bumps will get ultrasound. You ultrasound, you needle, you find thyroid cancer. It's not just thyroid cancer. This is melanoma. Melanoma has a fairly stable mortality rate in this country, but there's nothing stable about its incidence rate. It's up over threefold over the period. I showed you kidney cancer. I'm going to show it to you again, just so you see the picture. Stable mortality, yet 2.5-fold increase in its incidence. And I want to share with you an article by my colleagues and I that we published just about 2 months ago on the regional risk of CT imaging in the United States and the risk of nephrectomy. Kind of a crazy title, isn't it? So I'm going to show you on the x-axis hospital referrals regions, their proportion of the Medicare population who are exposed to chest or abdominal CT scans over 5 years. Among America's elderly, 65 plus, what proportion do you think have a chest or CT scan over the next 5 years? Any guesses? 25%? That's not bad. It's a little low. It's somewhere between 30 and 50%, depending where you are in the country. And this is another important point. There's a CT scan in your future. I suspect the lifetime risk of CT scanning in the United States is probably approaching 80%. Now, on the y-axis, I'm going to put the 5-year risk of nephrectomy or renal ablation. And now I'll throw the data on. These are the 70 largest hospital referral regions in the United States. These two variables are extremely highly correlated. The R value is 0.56, highly significant. And I'll show you the names. I'll name names. Upper right-hand corner is South Florida. They're always high on everything. Fort Lauderdale, Tampa, Fort Myers, Miami, Orlando. Down in the lower left-hand corner is Northern California, San Francisco, Santa Rosa, Salt Lake City's down there, Portland, Maine. This article led to the following tweet from the BMJ: more CTs, fewer kidneys. I think this largely reflects the higher portion of the population you scan, the more kidneys you look at, the more incidental detection there is of renal cell carcinoma. Oh, and then there's prostate cancer. It's the poster child for the problem. Let's take a look at its incidence curve. Can you believe that? This is a cancer incidence curve. I mean, I look at these things, there's no other curve that looks anything like this. Look how volatile this incidence curve is. And I don't care how much tumor biology you know or how much you know about the carcinogenic process and exposures, none of that can explain this graph. You have to know what's going on in the healthcare system. This is an unbelievable curve. It actually tracks the BlackBerry share price over the period. It's unbelievable. I mean, it's crazy. And of course, you all know what this curve reflects. It reflects how dependent the incidence of this cancer is on our scrutiny, how hard we're looking for. How hard we're looking for this disease. It's a scrutiny-dependent cancer. That first upward slope, slow upward slope, that's the transurethral resection of the prostate period. That's the period you guys are getting sent all these chips from the operation that we don't really do anymore because we have medical therapy for it. That big spike is the advent of free PSA testing when hospitals in the US were offering free PSAs to anybody at the mall, knowing full well that they would more than recoup any costs in subsequent biopsies and follow-up procedures. And then the flattening of the curve, when I call it the oh my gosh era. A lot of men have prostate cancer, and even the urologists agree. We shouldn't be screening people with limited life expectancy. And then that downward limb where there's really active discouragement of PSA testing. I can think of no better example of how important scrutiny is on the apparent amount of cancer. Oh, and you can get a dog for prostate cancer too. All right, so I've saved the best for last. Let's talk about the debate about screening mammography. And I want to be clear, there is no debate about diagnostic mammography. And it's really important to understand the difference. Diagnostic mammography is what we do when a woman presents with a new breast lump, and we're trying to sort out whether that lump is worrisome or not. No one disagrees about that. It's a good test. Nothing's wrong with mammography. The question is, to what extent should we be inviting women in to look hard at them to see if we can find something wrong? Now, I want to start with the good news, because there is good news in breast cancer, and often you don't hear that. And the good news is about breast cancer mortality. It was pretty stable until about 1990, and then it's really started in a steady decline. And that is unambiguous good news. It is down by over a third. So that's great news. We should celebrate it. No questions about that. Now, this decline is observed in both women of screening age and in women who are younger, those who are rarely exposed to screening. What do you think that tells me? What's changed? Treatment. Yes, sometimes our treatments get better. This argues strongly that this is about treatment. In fact, the mortality rate is actually declining somewhat faster in women who are too young to be screened. Now, I'm going to show you the same graph again, but I need to make a little bit more room so we can show the incidence rate. So here's the mortality rate. That's the 1/3 decline right there. Now let's look at incidence. Whoa, it popped up during the decades of the 80s, when the initiation of widespread mammography occurred. Went from about 0% to about 70% of women over age 40. Now, I want to share with you one article that I wrote with Archie Blyer down at the University of Oregon. It's called The Effect of 3 Decades of Screening Mammography on Breast Cancer Incidence. That was not the original title. The original title was The Effect of 3 Decades of Screening Mammography on the Stage-Specific Incidence of Breast Cancer in the United States. But that violated the character count at the New England Journal, so we had to change it. But this is a more accurate title. So before I show you the data, I want to just give you my sense of the expected impact of an effective screening program. Imagine early stage breast cancer starts here and late stage starts here, which is about their respective positions. You initiate screening, what do you expect to happen? Well, you expect to find more early stage disease. That's what you're looking for. But at the same time, you expect to have fewer women present with late stage disease. It may be delayed in time, there may be a lag, but you expect to have, as you find more early stage disease, you hope to get women not presenting with late stage disease. In other words, the goal of screening is to take a woman who is destined to be on this curve and put her on that curve, such that when you put the two curves together, the overall incidence is roughly the same. Screening shouldn't cause cancer. It should change the stage. So, what really happened? This is the stage-specific incidence of breast cancer in women age 40 and older in the United States, the group that is exposed to screening. Well, early-stage breast cancer, just as you expected, popped up, coinciding with the initiation of widespread screening mammography. That's what you'd expect. The question is, what happened to late-stage disease? And the answer is very little. Very little. Maybe down a little bit, but it's very little change. Now, this imbalance suggests two things. One, screening mammography largely fails the first prerequisite for a successful screening program. That is, it's not leading fewer women to present with late-stage disease. That's the first goal of screening. And second, screening mammography is associated with a substantial amount of overdiagnosis. All this excess of early stage cancers and just a little deficit in late stage cancers. So that's stage. And one of the critiques we had from that article was, well, maybe stage has migrated over time. We've changed the way we measure it, and maybe we're doing more imaging, or maybe we're doing more sentinel node biopsies. Maybe we're upstaging people over time. So we decided to look at size, thinking that a centimeter in 1975 is still a centimeter in 2017. And coinciding with the advent of screening, there was a remarkable increase in the rate of detection of small breast cancers, less than 2 centimeters in size. What happened to large breast cancers over 2 centimeters? Not much. A little bit of a decrease, but not much. These data lead me to think that screening mammography has led to substantial increases in the detection of early stage and small cancer, but not substantial decreases in late stage and large cancers. Now, I want to be clear, there's a baseline assumption in my analyses, and that is that the underlying probability of clinically meaningful breast cancer has been relatively stable. And there are 3 findings that support this assumption. First, the apparent increase in incidence coincides with the initiation of widespread screening mammography. That's what you'd expect to see. You start screening and almost immediately you see a change in the incidence. This increased incidence is entirely early stage and small tumors. And third, the incidence of metastatic breast cancer, women who first present with metastatic disease, has been stable. Now let me just show you that. So here is the incidence now of all invasive breast cancer, no ductal carcinoma in situ here. And you can see that there is about a 30% increase in the 80s that coincides with the initiation of widespread screening mammography. Now let's say I'm wrong. Oh no, something really happened there. What would I expect? You know, there's some new exposure that very quickly, remarkably quickly, bumped the amount of genuine, clinically meaningful breast cancer. Well, then I'd expect to see something pop up in the metastatic breast cancer rate. But I don't. In fact, the rate of metastatic breast cancer at first presentation has been remarkably stable for the last 40 years. And by the way, whose fault is that? Is that the mammographer's fault? Are they doing something wrong? No. It's the birds' fault. They're already flown away. These represent the fastest growing cancers, the most aggressive cancers, the cancers that have already spread by the time they're detectable. And breast cancer mortality was totally stable through this period before it started to trail off as treatment began to improve. This picture to me looks like that increased incidence is all an artifact of screening. Now, this problem of breast cancer overdiagnosis and sort of the trade-offs in screening mammography are now being more widely recognized around the world. Here in the United Kingdom, the National Health Service now invites women to consider the option of having screening mammogram. And they have a booklet that sort of detail the benefits and the harms. And they say, overall, for every woman who has her life saved from breast cancer, about 3 are diagnosed with a cancer that would never be life-threatening. So I'd summarize that as the mortality benefit relative to the overdiagnosis harm is about 1 to 3. Now, the Nordic countries are also interested in this, and Norway now estimates that ratio to be about 1 to 5. And based on my work in the United States, I'd say it's closer to 1 to 10 in the United States. Why? Because we look so much harder for breast cancer. We don't just do mammography, we do 3D mammography. And we add on an ultrasound, or we use MRI, and our diagnostic thresholds are lower. And that's before mentioning all the false positives, which are unbelievable in the United States. In a 10-year course of annual screening, the expectation of having at least one false positive result, the probability is about 50%. And for me, any screening test that alarms half the population over a 10-year period is out of control. No European country would tolerate that. Now, I can't say there's a right answer here. There's a trade-off. Right? Clearly, there are apples and oranges. If there is a benefit, and I believe there is one, it's small, it's avoiding a breast cancer death. And you have to make judgments of how you feel about all the unnecessary treatment and going through chemotherapy and radiation, which also has some mortality risk, and all the false positives. There's no right answer, except that screening's a choice. It is not a public health imperative. And the way we've been talking about it is like it's a public health imperative. You must do it, and now we're measuring doctors on it. Are you doing it? And all of a sudden, it's the way we decide how good our healthcare systems are. You know, what proportion of women have we scared or coerced, threatened to go into mammography? Well, I hope you look at a headline like this a little bit differently. Molecular breast imaging nearly quadruples the detection for breast cancer. I think we've all been taught to think this is a great test. We should do it. Until you understand the problem of turtles, and all of a sudden you're saying 4 times as much breast cancer. That can't be good. Or this one. This is an ASCO abstract from a couple years ago. MRI could aid breast cancer detection in average risk women. They screened about 2,000 women. They gave them 2 annual screening exams. They found 1 cancer by mammography. They found 60 cancers by MRI. We cannot make judgments about our screening tests based on how many cancers they find. The best test isn't the test that finds the most cancer. The best test is the one that finds the cancers that matter. Oh, you won't believe this. Yes, a game changer. Ready for a game changer? Could a bra actually detect breast cancer? It doesn't look like that comfortable of a bra, does it? But you have to ask yourself, where are we going with this? Is this really the way we promote health in society? Have people wearing devices that are telling them every day whether they're about to develop cancer? Or maybe there's something good here. Maybe there's a good financial opportunity here. Maybe I can get one of you to help me with this. I mean, could boxers actually detect prostate cancer? And I'll tell you what, we'll throw in a dog. See, I think we could sell that? I bet we could sell that. Again, my take-home points. Not all cancers invariably progress. There is strong epidemiologic evidence of overdiagnosis of cancer in the thyroid, the kidney, the prostate, and breast, as well as melanoma. And you do not solve the problem of overdiagnosis by looking harder for small cancers. Now, before we end, I want to make sure I sensitize you to misleading statistics. I want to come back to Korea, and you remember that this is not a sign of thyroid cancer, right? And look at that 5-year survival rate for Europe. I mean, it's like they're a third world continent or something, right? I mean, we're so tempted to make judgments about the quality of treatment based on this statistic, right? We're really being invited to say, wow, the place to be treated is South Korea. But when you really understand this statistic, you understand how sensitive it is to diagnostic practices, that it probably tells you more about who and how people are diagnosed than it tells you about how well they are treated. It is a very misleading statistic in the context of early detection. If you're doing a randomized trial of treatment where all patients are diagnosed in the same way, and you randomize half of them to receive drug A and half to receive drug B, and then you ask how long they live, what their survival time is, or their 5-year survival rate, that's fine. But when you're starting to compare across time or across geography, when the mode of diagnosis is changing, it is a very biased statistic. Korea is taking credit for curing turtles. And it's not just Korea that misuses the 5-year survival rate. Now, in order to get CME credit, how many of you want CME credit? Just sort of seeing. Okay. You've got to get this question right. This is for the entire conference. If you get this question wrong, you get zip on the entire conference. Am I right? You're on. All right. So I'll go through it slowly with you. What is the fastest way to improve cancer survival rates? Pick one. A, high-dose chemotherapy followed by total body radiation followed by autologous bone marrow transplantation. No takers? Okay. B, high-dose NIH funding. No takers. Good. C, have every man, woman, and child donate $50 to the American Cancer Society. D, give every man, woman, and child a cancer diagnosis. I know it's absurd, but of course sometimes the absurd makes the point. I think you all understand if I found cancer in all of you, which pretty close I bet I could, if I was looking hard enough, 5-year survival rates would go through the roof. And sometimes the absurd kind of makes the point, oh, this is incredibly sensitive to who is given the diagnosis. This statistic is very sensitive to who is given the diagnosis. Cancer survival statistics are always biased upwards. They're only one direction. They're only raised by early detection. And then we get the problem of survivor stories. And they can drive screening to even more overdiagnosis. Here's how it works. The more intensively we screen, that is, the earlier age we start, the more frequently we do it, every year versus every 2 years. The lower our diagnostic thresholds to call it an abnormality, the higher resolution of our imaging equipment, all those things add to screening intensity. The more intensively we screen, the more overdiagnosis that occurs. And the more overdiagnosis that occurs, the more survivor stories there are out there. The more likely it is our patients have read about cancer survivors following a screening test, or more powerfully have one in their family or among their friends, someone who feels that they owe their life to the test. That makes screening appear all the more useful, which then circles back to foster more intensive screening. And this has been dubbed the popularity paradox. That ironically, the more overdiagnosis that a screening test produces, the more popular it becomes. I want to come back to Korea just for a second. This started with ultrasound screening in physicians' offices. Physicians were beginning to buy ultrasounds and they were offering thyroid scans for about $30. But what really fueled this epidemic were the survivor stories. They became part of a media narrative. And a lot of people began to hear of people who had an early thyroid cancer found and were doing well, or more powerfully knew someone. And that only ramped up the interest in more screening. More begets more. The more we test, the more diagnoses we make. And that shows up in cancer statistics as increased incidence. And maybe someone even uses the word, there's an epidemic out there, we got to do something about it. And that feeds back for more testing. And the more testing we do, the more overdiagnosis and early diagnosis. And because of lead time and overdiagnosis bias, that leads to increased 5-year survival. And it produces more survivors. And that feeds back to more testing. So, not all cancers invariably progress. Cancer survival statistics are always biased upwards by early detection. And I do have a third point. Physicians and patients receive feedback that apparently supports more screening. It is a very counterintuitive world, and one that I think we have to work hard at so we don't create more disease, induce disease in the population. We all need to apply some healthy skepticism about cancer screening. Thank you very much for your attention. I'll be happy to take a few questions. I think we got about 10 minutes.
Don't go away. We'll do some more of that in a minute.
Okay.
So yeah, this is the first time we've had questions in a while, so don't get up and walk out because you've just had a really stimulating hour. So please.
So we're going to number 4. Mic number 4, please.
I go along with everything you said, but in regard to kidney cancer, prostate cancer, breast cancer, when do we act? Do we wait till a patient has a palpable tumor? Do we wait till they have metastases? When do we act?
Well, thank you for the question. I think I won't repeat it because I think everyone heard it. The question is, when do we act? I think one of the things I'm trying to do is keep people from getting in that box. So I want to move the question up front. When do we look? Because it is very hard to stop once detected. But that's not saying that we can't. And that's what active surveillance is about. Active surveillance started in prostate cancer. Now it's moved to thyroid cancer. There's a trial in breast cancer. And with renal cell carcinoma, more and more small renal masses are being followed to try to see which ones grow and which ones do not. Number 2. Nope. That's you. Sorry.
Hi, my name is Mike Dugan. Very interesting talk, and you're probably right for several cancers for which there's little to be done for them. But there's one I'd like you to talk about, and that is colon cancer.
Yeah.
The Guaiac stool test was the only screening test that's been shown to really reduce the mortality of a fatal disease. And there are better screening tests than that available now. And if you look, and specifically if you could, address the issue of mortality disparities in colon cancer between countries like England, which don't screen very well, and countries like the US.
All right, colon cancer is a disease very close to my heart. My father died of the disease at age 60. So let me just say a couple things about colon cancer. First, colon cancer screening doesn't have the same problem of cancer overdiagnosis that the other cancers that I mentioned was. We don't see more surgery for colon cancer associated with screening. You're right, there are 3 randomized trials showing fecal occult blood testing lowers mortality by somewhere between 15 and 30%. And as I say, this is a screening test that doesn't have the same amount of cancer overdiagnosis. It may have overdiagnosis of the precancerous stage. That's another issue. Colon cancer mortality is coming down. That's great. It's been coming down ever since my father died of the disease. Started coming down 15 years before we really started screening. Something else is going on that's helping to reduce it. I'm not saying screening isn't playing a role, but there are multiple factors at work. But I will say, in the context of what I was talking to today, colon cancer does not have the same overdiagnosis problem.
Number 1 next.
Yeah, number 1.
I'm piggybacking onto the last one. I do not have screening mammograms.
Well, that's okay.
I would like to know if I should still continue getting screened for colon cancer.
There's no easy answer to that. Let me just say one thing. Let me tell you what I did. Okay, and I have a father who died of metastatic colon cancer. I had a colonoscopy at age 50, as my brothers did. I had absolutely no polyps, and now I'm done. I think I'm probably a below average risk for colon cancer, and quite frankly, and this is an important thing that I think we all need to think about, my biggest concern in life is not that I'm going to die from colon cancer. The event I most want to avoid is being in a nursing home, not recognizing who my daughter is or my wife is, or being dependent on others. My goal in life is not to live as long as humanly possible. Excellent. And that's one thing. And by the way, I'll say I'm not a social media type. I don't even have a smartphone. But I did see something on Sermo, which is like a social media group for physicians, where they asked physicians what they're most worried about in life, what diseases they're most worried about in life. And heart disease, the #1 killer of Americans, was down at 5%. What was up at 60%? It was Alzheimer's disease. Physicians were worried about living too long.
Can I ask one more?
What? Yes, one follow-up.
So I don't want to have a colonoscopy, so
Yeah.
I've been doing the annual
Yeah.
fecal immunohemoglobin testing.
Yeah.
So I probably have to keep doing that because that's not as good as colonoscopy.
No. Whoa. Now you sound like a gastroenterologist. We don't know how good colonoscopy is. We are in the middle of a randomized trial of FIT testing. That's the fecal occult blood with histoimmuno. You guys know what it is. I don't know what it is. Some immunochemical staining. FIT testing versus colonoscopy. And I think it's fair to say we really don't know which one of those are better. We have 50,000 veterans randomized right now in the CONFIRM study. It'll still be about 10 years before we know the answer to that question. But if you're comfortable with FIT testing, I'd just continue with it.
Number 4. Yeah, you don't know your number 4 because the number's in front of you, but that's microphone number 4.
Sorry. I think that there is no doubt that if we can detect a precursor and somehow ablate it, we are having an effect downstream. That's for cervical cancer, it's possibly for colon cancer. But there are other cancers that, if they are invasive, they are basically not affected significantly by this. And your presentation was very nice, and I think that it was very welcome. But I think that we also, as pathologists, have participated actively in this. I mean, we have lowered our thresholds for calling things cancer significantly and constantly. Whenever a new entity is described, there is not even a question of why is this cancer? It's cancer. It's much more publishable if it's cancer. It's more interesting in general if it's cancer. So I think that even without having any wish to cause harm, we do so every day. And that's also true for the DCIS.
Yeah. Well, I really appreciate your comments, and I do think you pathologists share some blame in this game. We've all sort of driven down to the, wanting to call, if there's any, we only care about mistakes in one direction, and that's not, and patients are hurt in both directions. We got to be clear. You can undercall and you can overcall and put people through a lot of therapy that they wouldn't otherwise need. So we all need to find the balance, and that's the first thing to recognize is there is a balance here. And I also want to say, and I wrote this in my first book, is it's possible we're asking you to do an impossible job. We're asking you to make a static observation on a single set of cells and make some prediction about future disease dynamics. And that may be fundamentally an impossible job, or it's certainly going to be a job that is filled with error. One thing that I think we're beginning to do that's really smart is we're beginning to make use of the diagnostic value of time. And that was really in the context of lung cancer screening, where when we see a small abnormality that looks like it might be a cancer, instead of biopsying it, we're asking the question 3 months later, does it grow? And that's a pretty fundamental question that, as far as I'm concerned, excuse my language, trumps all the other information. It provides phenotypic and genotypic information.
So forgive me, we can only take one more question, and the guy at number 4 has been there for quite a while, so.
I was going to ask about the colon, but you've already dealt with that. Cervical screening, that has been touted to be very successful.
Yeah.
I do have a third question. Should I stop having any more PSAs now that I'm normal?
Well, by the way, this is a question I can't tell you the right answer. This is a question you should be asking yourself. And the idea that there's one right way for everybody certainly is not correct. It is about very dissimilar events. Do I think PSA has had some role in lowering the mortality rate from prostate cancer? Yes, I do. Do I think it's led millions of American men to become impotent and incontinent? Yes, I do. What do? I choose not to be screened, but that's my choice. I'm not saying it's the right thing. That's what's right for me.
All right, so please, all of you, join me in thanking Gil for the most wonderful lecture.